Good day everyone, I am Mr. Philip J. Zhao, and today we are going to discuss about the viral diseases of the lower respiratory system. For a virus to reach the lower respiratory system and initiate disease, it must pass numerous host defenses designed to trap and destroy it. Nonetheless, numerous respiratory ailments are caused by viruses. A newly introduced test, the XTAG respiratory panel, can diagnose a dozen such ailments at a time. First, we have the viral pneumonia. Viral pneumonia can occur as a complication of influenza, measles, or even chickenpox. It is a number of enteric and other viruses have been shown to cause viral pneumonia, but viruses are isolated and identified in fewer than 1% of pneumonia type infections because few laboratories are equipped to test clinical samples properly for viruses. In those cases of pneumonia for which no cause is determined, viral etiology is often assumed if mycoplasmal pneumonia has been ruled out. In recent years, coronaviruses have emerged as causative agents of pneumonia. In 2003, SARS-associated coronavirus emerged in Asia and spread to several countries. Since 2004, no known cases of SARS have been reported anywhere in the world. In 2012, Middle East Respiratory Syndrome coronavirus or MERS-CoV was first reported in Saudi Arabia and then spread to several other countries. PCR is used to confirm SARS and MERS-CoV. Next is the respiratory syncytial virus. Respiratory syncytial virus or RSV is probably the most common cause of viral respiratory disease in infants. Actually, there are about 4,500 deaths from RSV each year in the United States, mostly in infants 2 to 6 months old. It can cause also a life-threatening pneumonia in older adults, where it is easily misdiagnosed as influenza epidemics occur during the winter and early spring. Virtually all children become infected by age 2, of whom about 1% require hospitalization.
Respiratory syncytial virus infection. The quick facts. The respiratory tract is the parts of the body related to breathing, including the nose, windpipe, air passages in the lungs, and the lungs. RSV is a virus that infects the respiratory tract. RSV infections spread easily among babies and children, usually in winter and early spring. Nearly all children get the virus by age 4. RSV causes runny nose, fever, cough, and wheezing. Most children don't have problems, but severe infections cause trouble breathing and low oxygen levels. Someone can have RSV more than once, but symptoms are usually milder after the first time. What causes RSV infection? RSV is one of many viruses that infect the respiratory tract. Others include the cold virus and the flu virus. When someone with RSV coughs or sneezes, a nearby person can get the virus by breathing in or touching droplets in the air that have the virus. What are the symptoms of RSV infection? Children usually get symptoms like runny nose, fever, cough, and wheeze, a whistling sound when breathing. In older children and adults, symptoms usually aren't serious. However, in babies, symptoms can be severe. In babies younger than 6 months old, the first symptom may be a temporary stop in breathing, apnea. Sometimes young babies have serious breathing problems with severe wheezing and low oxygen levels in their blood. How can doctors tell if my child has RSV? There are many viruses that cause the same symptoms as RSV, and doctors don't always need to tell them apart. But if they do, doctors test samples of mucus from the nose. How do doctors treat RSV? Most children get well at home with rest and fluids. If they have trouble breathing, doctors treat them in a hospital with oxygen. Nebulizers with medicine that stops the wheezing and asthma don't help much with the wheezing and RSV infection. How do doctors prevent RSV? There is no vaccine to prevent RSV. People with young children should wash their hands a lot to keep from passing on the virus. Rarely, doctors give monthly shots of medicine that can make RSV infection less severe. They use this medicine only in children who are most likely to have serious breathing problems from RSV. For example, young children who have serious heart or lung disease, or those who were born very premature.
Next is influenza. The developed countries of the world are probably more aware of influenza or flu than any other disease except the common cold. The flu is characterized by chills, fever, headache, and muscular aches. Recovery normally occurs in a few days, and cold-like symptoms appear as the fever subsides. Still, an estimated 30,000 to 50,000 Americans die annually of flu, even in non-epidemic years. Diarrhea is not a normal symptom of the disease, and intestinal comfort or discomfort attributed to stomach flu is probably from some other cause. There are two types of projections, one hemagglutinin HA spikes and two neuraminidase NA spikes. The HA spikes, of which there are about 500 on each virus, allow the virus to recognize and attach to body cells before infecting them. Antibodies against the influenza virus are directed mainly at these spikes. So the term hemagglutinin refers to the agglutination of red blood cells or hemagglutination, but occurs when the viruses are mixed with them. So this reaction is important in serological tests such as the hemagglutination inhibition test that often used to identify the influenza virus and some other viruses. The NA spikes, of which there are about 100 per virus, differ from the HA spikes in appearance and function. Apparently, they enzymatically help the virus separate from the infected cell as the virus exits after intracellular reproduction. NA spikes also stimulate the formation of antibodies, but these are less important in the body's resistance to the disease than those produced in response to the HA spikes. The mortality rate from the disease is usually not high, less than 1%, and these deaths are mainly among the very young and the very old. The most recent pandemic in 2009 involved an H1N1 virus, so this strain is always of special interest because the lethal 1918 pandemic was caused by an H1N1 virus. Fortunately, the 2009 virus was not specially virulent. This strain had apparently been circulating indefinitely in pigs in Mexico and Central America and had not been detected because there was little surveillance in that area.
In 1918, a new and unusually deadly influenza virus swept the globe in a pandemic that we are still studying today.
The 1918 pandemic caused the global deaths of probably 50 and maybe up to 100 million people, making it the worst natural disaster in all of recorded human history.
But what made the pandemic so lethal? NIAID's Dr. Jeffrey Taubenberger has been studying the 1918 flu for decades.
Most people who had influenza in 1918 had a completely typical course of influenza, like you would see today. But in 1918, a really unusually high number of people ended up having very severe illness, meaning that they actually developed a pneumonia, an infection of their lungs, that started out as a viral pneumonia and then rapidly progressed in most cases to a secondary bacterial pneumonia. They had no way to treat the viral infection, they had no way to treat the secondary bacterial infections, so these people were just really left, in a sense, to suffer. And this process, from initial onset of infection to death by bacterial pneumonias, usually took around 10 or 11 days.
Ordinarily, influenza is most deadly in the very young and the very old. But as Dr. David Morens explains, the 1918 virus was unusual.
The two things that were different in 1918 is the deaths in all those age groups were more than they had been in other pandemics that we had seen, and that there was a very high rate of death in people between the ages of 20 and 40, which had never been seen before and which had never been seen since.
To find out why the virus was so lethal, Dr. Taubenberger and other scientists retrieved samples of lung tissue preserved in paraffin from soldiers that had died of the flu. Eventually, with the help of tissue recovered from frozen bodies in Alaska, Dr. Taubenberger's team was able to reconstruct the 1918 flu virus.
Unfortunately, when you look at the genome of the virus and just compare it on paper to other influenza viruses, nothing obvious really pops out at you as to why it would behave this way. And yet we know that this virus is a really virulent and pathogenic virus. One of the things the 1918 virus did, it does in experimental animal models, and there's data to say that that's what happened in people, is that it induced a really strong and very unusual kind of inflammatory response. So that the body's response, immune response to the virus itself, contributed heavily to lung damage and pathology, and probably contributed to serious illness and death. So it's this very unusual inflammatory response that's one of the key active research focuses of my laboratory, to understand why the 1918 virus induced that, and what perhaps we could do in the future to try to develop drugs that might target or limit aspects of the inflammatory response as a way of treating severe viral infections.
Fungal diseases of the lower respiratory system. First is the histoplasmosis. Histoplasmosis superficially resembles tuberculosis. In fact, it was first recognized as a widespread disease in the United States when X-ray surveys showed lung lesions in many people who were tuberculin test negative. Although the lungs are most likely to be initially infected, the pathogens may spread in the blood and lymph, causing lesions in almost all organs of the body. So symptoms are usually poorly defined and mostly subclinically, and disease passes for a minor respiratory infection. So in a few cases, perhaps fewer than 0.1%, histoplasmosis progresses and it becomes a severe generalized disease. So this occurs when with an unusually heavy inoculum or upon reactivation. So when the infected person's immune system is compromised. So the causative organism, Histoplasma capsulatum or Histoplasma capsulatum, is a dimorphic fungus. That is, it has a yeast-like morphology in tissue growth, and in soil or artificial media, it forms a filamentous mycelium carrying reproductive conidia. In the body, the yeast-like form is found intracellularly in macrophages, where it survives and multiplies.
Next is the coccidioidomycosis, another fungal pulmonary disease also rather restricted geographically as coccidioidomycosis.
The causative agent is Coccidioides emetisa dimorphic fungus. So the arthroconidia are found in dry alkaline soils of the American Southwest and in similar soils of South America and northern Mexico. Because of its frequent occurrence in the San Joaquin Valley of California, it is sometimes known as valley fever or San Joaquin fever. So in tissues, the organism forms a thick walled body called a spiral filled with endospores. In soil, it forms filaments that reproduce by the formation of arthroconidia. So the wind carries the arthroconidia to transmit the infection. Arthroconidia are often so abundant that simply driving through an epidemic area can result in infection, especially during a dust storm. An estimated 100,000 infections occur each year.
Symptoms of coccidioidomycosis. The symptoms of coccidioidomycosis include chest pain and perhaps fever, coughing, and weight loss. In less than 1% of cases, a progressive disease resembling tuberculosis disseminates throughout the body. A substantial proportion of adults who are long-time residents of areas where the disease is endemic have evidence of prior infection with C. emetis by the skin test.
Diagnosis is most reliably made by identifying the spherules in tissue or fluids. So the organisms can be cultured from fluids or lesions.
but laboratory workers must use great care because of the possibility of infectious aerosols. So several serological tests and DNA probes are available for identifying isolates. A tuberculin-like skin test is used in screening. Amphotericin B has been used to treat serious cases. So however, less toxic imidazole drugs such as ketoconazole and etraconazole are useful alternatives. Next, we have the pneumocystis pneumonia. Pneumocystis pneumonia is caused by Pneumocystis jirovecii. The taxonomic position of this microbe has been uncertain ever since its discovery in 1909, when it was thought to be a developmental stage of a trypanosome.
Pneumocystis pneumonia, also known as PCP or pneumocystosis, is a form of pneumonia that can be life-threatening. It is caused by a yeast-like fungus known as Pneumocystis jirovecii. It had previously been incorrectly classified as a protozoan. This pathogen is specific to humans and has not been shown to infect other animals. Its former name, Pneumocystis carinii, is still in common usage. As a result, pneumocystis pneumonia is also known as pneumocystis jirovecii pneumonia and incorrectly as pneumocystis carinii pneumonia. Pneumocystis is commonly found in the lungs of healthy people. Since it is a source of opportunistic infections, it can cause a lung infection in people with a weak immune system. Infections are frequently found in people with cancer, HIV and AIDS, and in those that use medications that suppress the immune system. Since the beginning of the AIDS epidemic, it has been closely associated with PCP infections. Pneumocystis jirovecii is found worldwide. Some reports show that 75% of children by the age of 4 are seropositive to the microorganism. This suggests a high background exposure. The concept of human-to-human transmissions of the fungus has been gaining recognition in recent years. Symptoms of PCP include fever, non-productive cough, shortness of breath, weight loss, and night sweats. The fungus can also invade other visceral organs, including the liver, spleen, and kidney. This only occurs in a minority of cases. These are just a few things to know about pneumocystis pneumonia or pneumocystis jirovecii.
Then we have the blastomycosis or North American blastomycosis. Cutaneous ulcers commonly appear and there can be extensive abscess formation and tissue destruction, so the pathogen can be isolated from pus and biopsy specimens. Amphotericin B or itraconazole is usually an effective treatment.
Blastomycosis is a disease caused by the fungus Blastomyces dermatitis. It is found in parts of the south central, southeastern, and midwestern United States. The fungus can be found in moist soil enriched with decomposing organic debris. During specific conditions of humidity, temperature, and nutrition, the fungus can grow and produce the infecting particles known as spores. The spores become airborne when the soil in which the fungus is growing is disturbed. This aerosol is then inhaled by humans or other mammals. Activities that involve disrupting the soil are likely to put a person at increased risk for acquiring blastomycosis. Persons in areas with endemic disease with exposures to wooded sites such as farmers, forestry workers, hunters, and campers are at a greater risk of exposure to this fungus. In endemic regions, it may not be possible to completely avoid exposure to the fungus. However, those who are immunocompromised may consider avoiding wooded areas where and when the fungus is prevalent. Infected individuals may not develop any symptoms or may develop mild and rapidly improving respiratory symptoms. Symptomatic infections usually presents as a flu-like illness with fever, chills, productive cough, and other symptoms. Some patients fail to recover and develop chronic pulmonary infection or widespread disseminated infection. Blastomycosis can also occasionally affect the central nervous system, resulting in meningitis. Symptoms may appear between 3 and 15 weeks after exposure. Fortunately, blastomycosis is not known to be transmitted from person to person. These are just a few things to know about blastomycosis. To learn more about infectious environmental disease testing services and prevention measures, or other indoor and outdoor environmental concerns.
Then we have the other fungi involved in respiratory disease. Many other opportunistic fungi may cause respiratory disease, particularly in hosts who are immunosuppressed or have been exposed to massive numbers of spores. So aspergillosis is an important example. It is airborne by Conidia of Aspergillus fumigatus and other species of Aspergillus.
which are widespread in decaying vegetation. Compost piles are ideal sites for growth, and farmers and gardeners are most often exposed to ineffective amount of these conidia.
Aspergillosis. Aspergillus species have a wide geographical distribution and are often found in decaying organic matter. Conidia are released into the environment and then are inhaled deep into the lung air spaces. In one of the classic forms of this disease, invasive pulmonary aspergillosis, the conidia are inhaled into the alveolar air spaces, where the conidia germinate and become hyphae with invasion into pulmonary vessels. At this early stage, plain radiographs may not be revealing, but CT scan of the chest shows nodular lung lesions surrounded by a halo of low attenuation, reflecting hemorrhage around the fungal cell mass. Eventually, this lesion may cavitate with development of an air crescent sign, which is a favorable prognostic sign. Subsequently, with vascular invasion, the infection disseminates to liver, spleen, kidney, skin, and brain. This form of disease has an extremely high morbidity and mortality and requires aggressive surgical and medical therapy.